So, welcome. We had a great day yesterday, and we're excited for this panel. I'm going to do just a quick kind of context, because we have the experts here on the panel, and I just wanted to give you a little bit of background. So today, you're going to hear from Keisha Zhu, who is the product manager at Clover Health, Kia Williams, co-founder of Serum, and Jonah Froelich, who's managing director at Manette Phillips. Phillips, and you added the Phillips since I had been watching. So, in any case, I just wanted to give you a little bit of background. The talk today was really focused around effective new service delivery models in healthcare, and the term on the title in public health may confuse some of you, and so we'll really put context around this. This is around healthcare delivery models. And so I just wanted to open up with a little bit of why. Why are delivery models changing in healthcare? And first of all, the government is driving this. Payment is changing, and Jonah will go into more depth around the payment changes and the drivers, but just to get a sense of this audacious goal that has been set by the Center for Medicare and Medicaid Services, around 90% of payments will be tied to value and quality by the end of 2018. And so that's a big, big shift that's coming on its way. And the delivery system is starting to wake up and notice that. It's also being driven through state programs, and so the state innovation models now in 17 states testing different models of payment and service, and the delivery system incentive payment reform, DSRIP, which California actually has DSRIP programs, and then also funding coming through the private sector for a number of different ways to incentivize a transformation in delivery systems. And I'm just going to breeze through these slides because Jonah will go into more detail on this, but I'll tell you what, there's a lot of acronyms up here, and there's a lot of things to follow. You can find both this slide and this slide, which I thought I'd just put in there, on the CMS website. And if you're interested in knowing the way these programs are linking together and how government's driving this, these are really good slides to look at and kind of see how it's really supposed to all tie together. But there's also some drivers that are occurring in the private sector, and so I just thought I'd mention a couple examples of those. One is a private sector initiative that my consulting firm has been supporting. We're in our third year of supporting Intel Corporation, and what they are doing is quite different in the arena of employer-sponsored health plans, where they're contracting directly with the delivery system, and one of their measures, one of their requirements for this value-based plan is that the delivery system has to prove that it is exchanging data electronically with national standards. And so this is something that is actually creating measures and creating a great feedback loop to the Office of the National Coordinator for Health IT around what's working, what's not, as you start to see the push that is being able to be accelerated by an employer as a health plan provider, and so payers of all types will have an influence. And then another example are value-based coalitions that are forming with health plans, and the example that I have here is committed to 75% of their respective business being in value-based payment models. So basically, this is, my last slide, and it's really about consumer views are changing as well. I thought this was an interesting slide because it was just only a few years ago that retail clinics really started to make a difference in terms of the delivery system. And now you can see in this particular research that was done by Oliver Wyman that, gosh, 31% of the people interviewed thought that their experience of getting healthcare through a retail clinic was actually better than their primary care provider. So with that, I'm going to pass this along to Jonah, and we're going to have to switch over to his slides and let you introduce yourself and your role.
I'm going to stand for this. I'm Jonah Frolick. I'm a managing director with Manatt Health. We are an interdisciplinary law consulting firm. Been around for about 50 years. I'm going to give a little bit more of the broad context of delivery system transformation and payment reform, and I think that'll lead into some interesting discussion. So before I go, how many of you represent a payer? One. How about a provider? A few. How about a technology company? What did I miss? MSO. MSO?
Payer group.
Payer group.
Pharma.
Pharma. Anybody else?
Consultants.
Consultants. How many of you are consultants? All right. Okay, so I'm going to start really sort of with the high level, sort of four things that are really influencing market trends right now. One is really around the consolidation factor. Providers, physicians, hospitals are increasingly grouping together and forming systems, and I'll show you what some of those data look like. There's tighter integration with those doctors between hospitals and physicians. There's an increase in provider accountability and risk-based payment arrangements, and that has all been pretty rapidly increasing over the past few years. About 42% of recent hospital surveys responded that 10 or more % of the current revenue is tied to value-based payment, and they expect at least half of that will be tied to value-based payment in the next 2 years. That's a huge change in terms of reimbursement. And then federal and state payers are advancing different kinds of value-based payment arrangements. And Carol mentioned a couple of those, and I'll show you a few of those now. So first, in terms of the first influencing factor, market consolidation. So with the exception of a little blip, 2009, which was our the collapse of our financial market, there has been a steady stream of consolidation in hospital systems. And this is just through 2012. The trend has continued. And this doesn't even account for things like joint ventures between various systems, which have multiplied exponentially, really. The second is around physicians. So if you look at the trend just in the last 10 years or so, you're seeing over half of physicians who are independent, who had their own practices, who are not directly employed by another health system. And that's declined to about a third. At least that was in 2013, and that number continues on that trend. Now, we've gotten to a point where 2/3 of physicians who filled jobs in 2013 went to a health system. And there's no change in that. And some of the things you'll see in that slope, some of the things you'll see in a moment are really just going to accelerate that trend. So next, risk-based reimbursement. So when you ask health plans how they're changing, how they pay for services, about half of the arrangements that plans typically have, 56% today, are fee-for-service based. That's going to change to less than 1/3 in 5 years. And so plans are increasingly putting things like value-based payment arrangements like shared savings, capitation, bundled payments into place. And so on the commercial side at least, and this is Medicare Advantage too, it tracks closely, much more focus on what am I going to get for this payment that I'm making to you provider, to you health system, not just fee for service. I want some value demonstrated in that payment. And then Carol mentioned this. Medicare has become the leading trailblazer for payment reform. So 50% in the next few years of payments for Medicare are going to be what they call alternative payment models. These are these categories 3 and 4 that they published a few years ago, or a couple of years ago. And that means ACOs, medical homes, bundle payments, half of the payments that Medicare makes are going to be in this fashion. And 90% are going to be, are going to have some sort of correlation with quality. So it might be something like an incentive payment program for reporting quality initiatives, quality measures. So we're going to see a really big change in the next few years on Medicare in terms of how they pay. So, what are a few of the things that have happened recently that Medicare has announced? The Affordable Care Act in 2010 has led to the creation of ACOs, over 300 Pioneer and Medicare Advantage ACOs. 2013, you saw the beginning of bundled payment initiatives and something called the Comprehensive Primary Care Initiative. If anybody's familiar with that, in 2015, or actually this year, 2016, they announced the CPC Plus, which is the next generation of the Comprehensive Primary Care Demonstration, a massive program that they're trying to get all small and solo physicians into some form of medical home model, trying to get physicians aligned in terms of the quality of care that they deliver. And then last year, MACRA was signed. And MACRA is probably the single biggest driver in health payment reform that Medicare has ever undertaken. So MACRA is the Medicare Access and Chip Reauthorization Act of 2015. And MACRA basically is a complete bellwether for where Medicare is going to go around payment. And if you're a physician that participates in Medicare, which means you're a physician that practices medicine in the United States, except for maybe some pediatricians, then you have a choice. So you've got you take the blue pill and you go down the MIPS route. And the MIPS route basically says you've got all of these different kinds of quality initiatives, payment type of reporting requirements, and you can go that track. And if you do that, then you don't have to become an APM, or what really is an ACO. So if you go down that track, then you essentially have to join forces with a health system and become a two-sided ACO, which means you're going to have to accept upside and downside risk. So what is the implication of this choice? This is the way of MIPS. PQRS, meaningful use, and what's called the value-based modifier, all get folded into a new incentive payment program. And what this means is that over the course of a number of years, starting in 2019, then you will start to see a ±4 graduating up to a ±9% hit on your payment as a physician participating in Medicare. And that can actually be scaled up where there's this exceptional performance adjustment, $500 million a year, which means that if you're a physician, you could see an upwards adjustment of 19% in your pay if you are in the top quartile of physicians in the Medicare program. But the plus and minus 9% here, that's budget neutral, which means half of physicians are going to see deductions in their pay from Medicare if you're in MIPS. Medicare thinks that most physicians are going to be in MIPS, and that's because the alternative is the APM model. And the APM model basically is, as I said, it's an ACO. It's a Track 3 or a next-gen ACO program. It could be something like the CPC Plus, which is, as I mentioned, another kind of medical home type model. But what it basically says is if you participate and qualify for an APM, then you are eligible for a 5% bonus every year, no downside, so you're not eligible for this 9% reduction in fees, and every year you get 0.75% increase on your base pay. The MIPS track is just 0.25%. So they're trying to direct physicians into one or two models. And in one case, there's a huge potential hit on the take-home pay of a physician participating in Medicare if you're in the bottom half. So what else? Carol also mentioned this, Medicaid. Medicaid is actually now the biggest single payer in the country. There are now over 70 million people that are covered by Medicaid. There are 13 million Medicaid people on the rolls in California today. 1 in 3 people in California. So you can't ignore it anymore. Payers can't ignore it. Providers can't ignore it. There's a whole broader range of approaches that states are taking with respect to Medicaid and value-based payment. Some are requiring participation in Medicaid managed care, and for plans to have all sorts of value-based payment arrangements. There are Medicaid-specific issues to value-based payment. There's a strong focus on social determinants of health. Who's heard of social determinants of health? So if I asked you 5 years ago, would you have been able to say, I know what social determinants of health are? Most people don't, because most people hadn't. And what the focus now is on things like integrated behavioral health and how do we take care of the housing problem that many of the people in Medicaid have, because you cannot fix them. You cannot help them get healthier if they don't have a place to live, or if they don't have the right level of education to get a new job. So a lot of the new features, and California is one of them, incorporate social determinants into some of their health programs, which is really unique. So, and then there are other states that are relying on what Carol mentioned, these district programs, multi-billion-dollar programs for states. A couple of examples: Massachusetts is requiring, this is for Medicaid, is requiring 90% of its payments to be on value-based payment arrangements. South Carolina, 20%. All Medicaid MCOs, managed care organizations in Minnesota, have to participate in ACOs. Arkansas, which is, believe it or not, probably the leader in alternative payment arrangements, has 16 episodes of care payment programs, payment arrangements. So this is all sort of leading towards this integration of care across the delivery system. So what does this look like? If you're a hospital, what you see is on one scale, hospitals buying other hospitals, they're affiliating with hospitals, they're building new hospitals, they're becoming much more scalable, much bigger. The care continuum, they're trying to align everything from primary care all the way to the home. So they're either making acquisitions, joint ventures, or they're partnering. And then they're increasingly purchasing or participating in health plans. So over 100 health plans in the United States, 5% of people enrolled are enrolled in plans that are owned by a hospital or a health system. And that trend is increasing. It's been increasing in the last 5 years. And then finally, what are they doing with those plans? They're actually creating them, and they're creating their own networks, sometimes with partners, with other health plans, or not. But when you look at the largest cities in the US for public exchanges, more than half are either tiered narrow or ultra narrow, which means we're kind of back in the days of capitation where you had a narrow network and not a lot of choice. So with that, I think I'm going to turn it over to one of my other colleagues.
My name's Gerda Zhu. I'm one of the product managers at Clover Health. And Clover Health is essentially, it's a technology company that's building an MA plan from scratch as a way to create a technology and operations stack that can dramatically improve outcomes for our patients, and also partner with physicians so that they can operate in a world where they are sharing a greater piece of the risk. And the reason that we chose to use MA as a vehicle for this is, as the payer, you're in quite a unique vantage point. Not only are your incentives well aligned with your patients in that you want to prevent a hospitalization as much as they don't want to go to hospital, you're also in a vantage point where you're actually connected to all the disparate and fragmented parts of the current system. So a great deal of the challenges that we face in this new world is, how do we do more effective care coordination? How does a hospital inform the PCP of an admission into the ER? Or how do we identify that a patient is not adherent to their medication from the pharmacy data because they haven't filled their 30-day prescription? You know, these are all operational and data challenges. They're not challenges that require science and at the cutting edge of science, let's say. And so as the payer, you've got this unique position where you do interact with all of these people because they want to get paid. And so what we started doing was to look at this as a data and a technology problem, and first begin by integrating with these different actors so that we can build a more complete understanding of our members. And then use that as a way to support the physicians that our members go to. And the fundamental thing that we're saying is that whilst the sharing of risk with providers is great in that it's creating greater accountability for the care that they deliver, to just put the onus on the providers to figure it out is really wrong. Fundamentally, they're coming with clinical expertise, but these challenges are logistical and data challenges. And to presume that there are off-the-shelf packages that they can buy if they are sufficiently financially incentivized is incorrect. But right now, no one really knows how to do effective care management. No one knows how to make use of this data. And so what you have to do is come at it from the standpoint of saying, well, first let's link up all of these disparate pieces of data, and then let's partner with people on the front line so that you can start creating these effective feedback loops to then start addressing some of these issues. So one example is how we partner with providers and pharmacies to deal with medication adherence. So we can identify when patients forget to fill their prescription, and as such, we can then send NPs to their home and talk with them to try and understand, why is it that they're doing this? Is it actually a problem of education, or is it actually more socioeconomic conditions? And then we can help them get them onto financial assistance if that's partly it. Is it one of access, one of transport? From our data, we can see which pharmacies people are going to, and we can also identify when they're going to more costly ones. And so we can start addressing those issues that are creating these barriers that are not medical, and essentially allow them to access the care that they need. But more so, we can then start using this information and piping it back to our providers and supporting them and filling in these gaps so that they can ultimately play a more active role in the health continuum of these patients.
Thank you. And Kia Williams, co-founder of Serum.
Hi everyone, I'm Kia. I'm one of the co-founders of Serum, and we're basically like a Match.com for unused medicine. We connect surplus unused medications with people in need. So I want to start with kind of two of the big figures out there that I think are really relevant to this conversation. One, that there's $5 billion of unused medicine that's going to waste every year. At the same time, there's 50 million people in the United States who can't afford the medicine they need to stay healthy. So that's about 1 in 4 working age adults right now who can't afford the medicine that they need. And we know that prescription drugs, that taking medication is the most cost-effective way generally to treat disease. So what does this really mean? For individuals, we're in this instance of low-income people, for example, in California, they're spending about the same amount on prescription drugs for a year as they would for their family for 3 months of groceries. So this kind of helps contextualize just how much things like out-of-pocket costs are around, if someone has a high copay, high deductible, or is generally uninsured. And we're seeing, and throughout our network, we see that generally if you're uninsured or underinsured in the United States, you actually pay more than someone who has insurance for these exact same medications. At a systemic level, the American Academy of Preventive Medicine actually showed that people not taking the medicine that they need cost our health system somewhere around $100 billion every year. We know that about 125,000 people die every year because of medication adherence issues. That's actually more than motor vehicle accidents every year in the United States. So essentially what we're trying to do is connect this vast amount of surplus, which $5 billion is not a small number, but the kind of trickle down, the impact on our health system is even greater when folks don't take their medication, and we know that medications are just one of the rising costs in healthcare, and connected to those 50 million people. Also, another thing about those 50 million people, about half of them are insured, and about half are still uninsured. So we know the Affordable Care Act, has insured millions and millions of people, but there still are best estimates, at ultimate kind of achievement of the Affordable Care Act, if you kind of suss out, folks who can't maybe afford to buy a plan still that's subsidized or unsubsidized, we're still looking at, somewhere around 20, 25 million people who are uninsured. On the underinsured side, we're just seeing a ton of folks who, be it specialty drugs, be it mental health medications, be it things like unit of use, branded inhalers or, injectables, et cetera. We're seeing through some of our partners, folks who are coming in needing medications that are keeping them out of the hospital, things like post-surgical injectables like Lovenox or, other inhalers, et cetera. We're seeing them paying upwards of $300-600 every month. So there's still this really big challenge of what do you do if you are a low-income person in the United States in accessing medicine. And I think Kedja talked a little bit about this kind of medication adherence issue and this feedback loop where, people want to get healthy, they want to stay healthy, and oftentimes there are these fundamental issues around things like it could be transportation or the cost of transportation to the pharmacy. you know, what we're seeing in our partner and our networks is basically folks who are saying, yeah, this was my copay, or actually I haven't hit this deductible amount, so it's going to be about the same amount as my rent this month. So the way that we work is we basically go out and source kind of surplus, unused, unexpired medications from places like everywhere, like nursing homes, assisted living facilities, to actually pharmacies, manufacturers. Everyone just has this small amount of surplus. If you think 1%, 5% across, you know, thousands and thousands of pharmacies, nursing homes, etc., that ends up being quite a bit of medication. The way that we work is we connect them generally to community-based, so safety net pharmacies and clinics. So we're working a lot with federally qualified health centers that may own and operate their own pharmacy. We actually have a great partnership with Santa Clara County, for example, which launched Better Health Pharmacy in downtown San Jose, which allows any person to come in with a valid prescription and receive medications at no cost. You know, we're seeing these examples where, you know, big systems are finding a lot of value and saying, hey, wait, we own and operate the hospitals, we own and operate the jails in some cases. There's a lot of financial benefit for us to actually provide medications, you know, for patients who can't afford them before they end up in our emergency room, before they end up with a serious mental health issue in our psych ward. So we're essentially partnering with a lot of these systems that are really looking at how do we kind of create more cost savings across the board and really focus on getting people in the beginning rather than having them end up in the emergency room. So we work with a lot of those types of health systems. We're also still working with quite a few, you know, free clinics, nonprofit clinics that aren't associated with big health systems. A lot of the partners that we're seeing across states like California, Colorado, Oregon, Ohio, there are still a lot of folks who are being driven to, you know, the kind of clinics that are operated a few nights a week with volunteer providers who are coming in and, you know, they're needing their diabetes medicine or medicine for hypertension, hyperlipidemia. So there's kind of that, we're kind of a vast network of safety net. We're really starting to focus on how do we provide more kind of savings and quality support for these bigger health systems, but we are still actively seeing need from a lot of the kind of free clinic safety net, you know, that's very volunteer or nonprofit driven.
Thank you for each of those descriptions, both on payment, the driver to new delivery systems, and on a couple of great examples, of which there are hundreds and hundreds of examples, even just floating around this conference. One of the things that I'm thinking about is, and this is the second time I've heard what I would have thought was a payer, a health plan, describe themselves, describe their company as a technology company rather than a payer. And the first time was a few months ago, and it was a very large national plan. They said, we're really a technology company. And I thought, oh, that's interesting. And then when you said that today, it really caught my attention as well. So I'm wondering, Keisha, if you could just expand on that a little bit more and talk about the ways that you're seeing the use of technology helping the people you cover through Medicare Advantage plans, and where you see the forefront driving that in that age group particularly.
Yeah. So I'll focus on what I think is the more interesting part. I think the data piece, there are people who can talk more eloquently about this, and I think we'll appreciate how tough interoperability is. I will say the way that we're approaching this is to, one, be the one that's responsible for ingesting this data and making it into a state where it can be operationalized. Where I think is actually the more interesting work is, what do you do when you have that data? What do you do when you identify someone who is at risk of being hospitalized because their A1C is not under control? And you know that because of this lab data point, and then also the fact that they haven't gone to see their PCP in 6 months. That to me is more interesting, and the way I look at technology fitting a role there is to say, well, how can we use technology to empower our frontline clinical workers to act on this information? Because it's not going to happen by us sending like emails with reams and reams of data to these people. It has to come at the point of care. And so one of the things that I'm really proud of at Clover is we're trying to look at this both as a technology and a human problem. So when I talk about the technology stack, I think that's reasonably evident, but the thing that I think is important is this human stack, and saying that these are people who are empowered by technology, but also the culture to act in the best interest of our member. So one example is our NPs that go and visit patients. So number one, they have our app and they go along and they fill out different clinical assessments, which is fine, it removes paper. But the more interesting thing is then, depending on what we find out about the member prior to that visit, we can push specific targeted questions and interventions to the nurse, so they can respond in a way that's tailored to that member. So if we know about this A1C risk, we can do a special screening there. If we know that they haven't had a mammogram, then we can make that part of the visit. Or if they are at risk of colorectal cancer, then they can take along an FOBT or talk to them about doing a colonoscopy. And so now you're having a much more nimble and flexible health delivery system where you're now able to respond to the data in more real time and allow the frontline workers to actually harness that information in a way that actually has something meaningful for the member. And our vision is really to partner with providers to give them that same kind of visibility into that data, not in the form of charts and reams of data, but just actionable things. It's saying, we believe this member is not adhering to their medication. These are some of the possible reasons we think. We'd like you to have a conversation with them, or we suggest that you talk to them about colorectal screenings, because we've seen that they don't have one on record. But this extends beyond just the clinical staff as well. We actually empower our call center staff to do this. Now, traditional payers will look at the call center and look at it as a cost center. And so you say, well, we need 500 people in Denver, so let's just drive down the price, let's get them to handle as many calls as possible. And what you end up with is a pretty bristly experience. Whereas we look at them as people who are also on the healthcare continuum. And so we're hiring people who have great empathy, who are not measured on the number of calls that they do, but on whether they can solve these members' problems. And so now suddenly you've gone from a very transactional interaction to one where you're actually having a meaningful engagement with these members, such that you build up a relationship with them. And then what happens is in our software, we can pop up an alert in the CRM where they're documenting stuff to say, Mrs. Smith is actually due an annual wellness visit from one of our NPs. And so now the agent, under their own judgment, can say, okay, this conversation is going well, I'm going to try and encourage them to do this. And say, well, thank you very much, Mrs. Smith. I'm glad we dealt with your billing problem. I noticed you haven't had one of our annual wellness visits. So one of our MP nurses is completely free. They come to your house and they do a screening. It'll be an hour. It'll be very comfortable. It'll be in your own setting. And then, so suddenly you've gone from something where it's a very transactional administrative function to one where you're now using this touch point to onboard people into a intervention that can close clinical gaps.
Thank you. And you said a lot of things that kind of touched on just how care is being delivered and will be delivered under these new payment models. So I kind of referenced stacking the hats on top of your head. You used to just be a payer, now you're a provider and a technology company. So Jonah, I'm curious what you're seeing in your work in terms of what patients want. Is it working better for providers to get incentive payments of some kind, to get a little bit more payment from the payer to do that interaction themselves. Well, as a patient, I'm probably going to respond better to my primary care practice calling me than my health plan.
That's them what they want.
So,
What do you want from your provider?
Quality.
Really? I would love quality. If somebody could tell me how to measure it, I think you can actually help with that a
We
little bit.
want more time, we want convenience features, we want to schedule online, get in, do telehealth. It's all about convenience and more time, attention and personalization.
What does everybody think about that?
That's lower bill.
Lower bills, quality, convenience, they want to be in and out. I have 3 kids, I want to spend my afternoon in the ER. No, I don't want to do that. I want to use my phone, I want to be able to access it. That's what they want. That's not what they're getting. I mean, retail clinics, you mentioned this, we published an article in the Health Affairs blog on Friday. And in that, we responded to another piece in Health Affairs about the costs of retail clinic, which I thought was a pretty poorly done article, quite frankly. What we're seeing with health systems is trying to create these nodes by linking with retail clinics so that they can actually have outposts, because people can't get in to see primary care. And you've got 30 million additional people who just got insurance, and we have a 20,000 primary care physician shortage that's looming, that's going to be here in the next 5 years. So not only do we already have a shortage of primary care, we're going to see that exacerbated because we've got more people with insurance and a shrinkage of the number of people graduating from primary care in medical school. So people want access, they want convenience. Most of the health systems today that I work for, they're mostly academic medical centers, they're larger health systems across the country. They totally get it, but they don't really know how to prioritize the investments they're making, because they're trying to go the data route. They're trying to get on top of their data, but most of them have had Epic for less than 5 years, so they're swimming in data, they don't know what to do with it. And they're trying to figure out, well, okay, what's my next play? So they're thinking population health. I'll buy another system and I'll bolt that on top of Epic, and then I'll get really confused. So that's one of the things they're struggling with. And the next thing is, well, how do I, and this is where most of them are going, how do I increase my primary care footprint? And how do I increase my post-acute care footprint so that I actually can link people with the CVS pharmacy where they actually go to get chips or their prescription with an immunization shot, or access. So my kid has an ear infection, I don't have to go to the emergency room. And once I discharge a patient from the hospital, because I'm in a value-based payment model, how do I link with a long-term care facility, a SNF, an LTAC, something like it, a rehab facility, where my costs are going to be lower, and I can actually try to trim some of the costs out of our total bundle. So they're trying to create those linkages, but they've got all these different priorities, and it's really challenging for them to say, is it 50 million for IT this year, and another 25 million for that ambulatory care outpost? What do I do about my social media presence? There's been a lot of competing priorities.
The one thing I wanted to add to that, I think that gets lost until kind of you're at the end point of healthcare, is transparency and pricing for consumers. This isn't something, healthcare is still an industry, one of the only industries where you can go in, have something done, and you have no idea how much it's going to cost you, and then you can get a bill 6 months later. And I think you see, and that's just like a terrible customer service experience. You would never drive away in a car and then say 6 months later you're okay with whatever bill gets sent to you, with just a flat number. And I think we see this especially in these pharmacy settings where it's like, it's very hard for a patient who gets a prescription, is trying to do all the right things, walks into the pharmacy, stands there, hands them the script, waits, 30 minutes, however long it takes, and then they come up to the window, the person's scanning in their prescriptions, and they're like, okay, that'll be $700. I think these are still some of the other, and people think about you want to schedule online, you want to have all this access, but I think the one other thing that doesn't hit you until it really hits you as a patient is this transparency in pricing and knowing exactly what you're going to get and when. I mean, because then it also eliminates, we see this a lot where folks don't understand what they can get, with their health plan, with their prescription drug insurance, and it could have been a conversation, and I think this gets challenging ethically. It could have been a conversation maybe at the provider's office, around what is actually being prescribed. I mean, that gets a little challenging as well ethically when you talk about, prescribing practices based on what a patient can afford. But that, to be honest, is the reality of what we're seeing. We work with a lot of clinics where they pull out the Walmart $4 formulary or Walgreens, $6 formulary, and a lot of providers are saying, okay, like I know you can't afford it, X, so we'll go with what's on this sheet. So I think another big thing that just the system needs to work on is how do we create better transparency and let people know what they're going to get.
Do we have some audience questions? Got one in the back. Do you want to speak loudly, or I can actually zoom back there?
It's okay. What's going to happen with physician behavior when all these performance metrics and quality metrics are imposed upon them? How do you see that impacting?
Well, their heads are exploding as we speak. When I showed sort of this trend in providers leaving solo practice and independent practice, MIPS and MACRA is just going to be like an accelerator on that trend. They can't take it. So I do a lot of work around the country with health systems doing clinical integration, and that's where that health system interfaces with the independent community physicians and says, join us. We're not going to employ you, but we're going to help you. You'll get on our contracts. We'll create all sorts of quality initiatives. We'll jointly develop protocols. We'll implement them together. We'll measure. We'll report. Then we'll go to the payers and say, we're one entity, and now you need to contract with us. 5 years ago, there were 24 CINs across the country that were legitimate CINs. There are now hundreds. Because physicians, when we go to them, they're like, I can't take it anymore. I don't know how to deal with the administrative and the regulatory issues that are coming my way. It's faster than I can deal with it. And if you're a 5-doc practice, it's faster than they can deal with it. There's no way they can keep up. So their reaction is, get me the hell out of here. Somebody buy my practice, or I need to go somewhere to be protected from the storm.
Other questions? One.
This is for Clover Health. How are you incorporating things like patient activation, motivational interviewing, readiness to change into your clinical model?
Yeah, so we see those as kind of part of the holistic patterns of health that you have to address. It's something that we're starting to work on. I will say that we are a new company and we're dealing with the kind of most high leverage things. That said, we are still using our operational stack to experiment. So one of the areas that we're using is taking our social worker team and community organizing team and trying to address some of the more social determinants of health, one of which is around loneliness, and trying to identify people who are living on their own through various data sources that we have, and then sending community workers out there to try and engage them in local community groups. And this is still kind of in its early days, but we are putting effort into trying to do more than just prevent a hospitalization directly, and looking at the things that are going to push these people into that high utilizer band in 2 years' time. So not just affecting things that impact our spending in this year or next year, but really trying to provide a more holistic experience for our members.
Additional questions? So I have a question about payers and how receptive, with so much transformation in the landscape, there still seems to be very little in adopting medtech, meddev, and non-clinical regimes or ways of dealing with rehab and various other kinds of ways other than the clinical route. So you're talking about driving out cost, but you're looking at a very narrow band. And I hear from a lot of innovators how difficult it is to get payers to actually pay attention. So I'm curious about how you see the landscape changing, if at all, and how people who are doing work that are really designed for this whole, a much broader, integrated, community-oriented, solution-driven, lower-cost approaches are hitting a brick wall time and time again.
I have a request. Can you repeat that on the mic? Because it could be
I'm not sure I could do that
Well,
justice.
let me try to translate. I think what the alternative care models, the variety of non-traditional types of care services, right?
Plus, med dev and med tech innovation that may be class one, they're not clinical devices, so to speak. They're
Right.
still going to serve patients a lot better than what currently exists.
So even in-home, monitoring systems, things that might be able to help people stay in their home longer, get the kind of communication between themselves and their providers, maybe a foot scanner to the podiatrist, something along that line. But we need them paid for. Somebody has to pay for it, right?
Yeah, so I actually came from a world where I was building such med tech and facing those same problems, so I can really sympathize with that. I do think there needs to be this kind of sea change, and one of the main issues that if you look at your traditional payers and the size of them, just imagine this company of thousands of people, and then what is the logistical overhead in rolling out the pilot? How do you run this up the flagpole? All the meetings you have to do, all the politics, just to get a small trial. It's extremely hard to do that. So I think, one of the advantages for us is we get approached, by virtue of being in Silicon Valley, we get approached by dozens of these companies all the time. And there are a lot of them show promise, and we are in the process of partnering with some of them. A lot of them just, I think the story is better than the results. You have companies such as Amada Health that have been at this for a long time and are doing really well. But then you have a lot of people coming to you and go, hey, yeah, I'm trying to improve medication adherence with this app. And the reality is our members are over 65. They don't need an app. They need someone to tell them where their nearest pharmacy that's in network is so they can save $10 a month on the pharmacy copay. That's going to have a more meaningful impact to them. I think a lot of the technology that's coming out of this area has been focused a lot on the things that the individuals who make them would want. And until that gap gets bridged, it's going to be very hard to create a meaningful story for the payers.
Well, that's probably not the answer you want.
Sorry, and I wanted to
I'm
jump
not
in.
talking about that.
Okay, I'm going to let you do a quick answer, and then we have another question that I know there's a microphone here, so and we're managing the time. We only have a couple more minutes.
Just to add on to that point, I do think that there is a little bit of bifurcation in the healthcare system that does have to be recognized based on patients. You're working with predominantly over 65. We're working with a lot of elderly as well as low-income patients where, all of us have an iPhone or a Samsung, whatever, have smartphones, have access to internet. There is still the highest risk populations, the most vulnerable populations that we're seeing. We're mailing them, we're mailing them information on local doctor's offices, or, people don't necessarily have internet access. We've had, online web forms that people are like, okay, I'm gonna go to the public library and try to fill this out for you. So I do think when it comes to kind of new devices, new technologies, you do have to recognize that there's this bifurcation, and the folks who are most in need, most vulnerable, don't have the same resources that you and I do, and there is kind of the human touch of picking up a phone and calling their house that has to happen, not pushing a text message to them.
Well, and that gap is closing, and there's statistics that it's gone from about 30% of Medicaid population with smartphones to 60% in that range now nationally. And I'm going to pass our last question.
Very quick question. This is regarding the payer architecture. Jonah, about 6 years ago, one of the CEOs of a large system was describing accountable care organizations, and he told us they're like unicorns. We all know what one is, but no one's ever seen one. Now things are a lot more clear, and I noticed everyone was taking photos of your slides. So do you have one specific resource that you could suggest to us to kind of update us on these things before our head explodes?
Sign up for Manat Health's newsletter.
A specific resource.
Kaiser Health News has a good news feed. So does California Healthcare Foundation's California Helpline. They just help you stay on top of daily media stories. We do have a newsletter, which I actually would recommend you go to, especially if you're interested in Medicaid policy, because our strength is really around Medicaid and policy strategic areas. So we cover everything across the country that's happening either at the federal or state levels. But we also have other news releases in some of our publications, and we do publish probably 2 or 3 white papers a month, like the Retail Clinic paper or various other topics that we cover. So those are probably the best, the ones I mentioned earlier, probably the best, just publicly available sources.
I want to thank our panelists, Clover Health, Serum, Manette Phillips, and thank you for coming today. We'll step outside, let the next panel get arranged on this, so if there's additional follow-up questions that you want, I'll commit the panelists to a few minutes with you outside. Thanks.
Thank you so much.